Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein, Becker, Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we will discuss the openEHR health data standards and the possibilities and benefits of using openEHR in the U.S. market. Hello, and welcome to our special series on interoperability. I'm your host, Nivedita Patel. I'm an attorney in Epstein, Becker, and Green's healthcare and life sciences practice based out of our Washington, D.C. office. In the past decade, certified EHRs have been instrumental in transforming medical records from paper to electronic or digital formats. Although this has fundamentally changed how providers and patients interact, there are still obstacles preventing providers from sharing patient data with each other or patients from sharing health information from their personal devices with their providers. This is due largely because patient data either becomes embedded in the application and health IT system they're collected in, or there is no compatible way for health information generated on a personal device to find its way into a certified EHR. As we focus efforts on achieving interoperability, critical steps have been taken to help address these issues. First, in the US, Fast Healthcare Interoperability Resource, or FHIR for short, was adopted by the Office of the National Coordinator as the standard for transporting specific data elements and groups of data. And second, openEHR, a technology for e-health data that can be used to create standards and interoperability solutions for healthcare, has recently gained traction in other countries around the world as it complements FHIR's transport capabilities. So how can FHIR and openEHR work together to solve for the storage and transport of healthcare data? On today's show, we're going to talk about openEHR and the emerging data solutions and legal pathways for U.S. businesses. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. I want to hand things over to my colleague, Karen Mandelbaum. Karen is a senior counsel at EBG and a former privacy and security official at the Centers for Medicare and Medicaid Services, with deep knowledge in all aspects of health data privacy and protection. Welcome, Karen, and thanks for leading today's discussion.
Hi, Nivedita. Thank you. Tomaž, I recommended that we invite you to participate in our Diagnosing Healthcare podcast series on interoperability, since you have been at the forefront of thinking differently about data in healthcare in ways that allow better technologies to be built for sharing data that can actually improve healthcare. We're so pleased that you agreed to join the podcast today. As the founder and CEO of Becker, Tomaž Gornik is a seasoned manager of teams building software products for more than 30 years. Tomaž is the co-chair of the openEHR Foundation Management Board and regularly speaks at conferences including Telemanagement Forum, HIMSS, Health 2.0, and Mobile World Congress. Welcome, Tomaž, and thank you for joining us today.
Thank you. Thank you for having me. Great to be here.
Let's start with some basics. Since openEHR has not been, as we just heard, has not been used in US, what is openEHR?
Yes, so openEHR has been around for almost 30 years. It came out of European projects that were trying to define the architecture of health IT systems, in particularly the data part. openEHR is a set of standards which are used to describe clinical data. They are so powerful that you can build platforms which manage clinical data using those standards. The standards are all open source, meaning they are free to use. And of course, the implementations of those standards are then either commercial or open source. But the whole idea is the management of clinical data. And what we'll talk about in the next questions is about how we try to separate data from applications. So it's actually a very different approach to the approach that HL7 uses, which is usually about keeping data in the same format as it is, and then exchanging some of the data using a common format. openEHR really addresses the issue of storing the data in an open format so that you do not have interoperability issues down the line.
Can you give us a little bit more information about this idea or the vision about separating data from the applications?
Yes. So the easiest way to explain this is if you look at the imaging world, the world of picture archiving, PACS systems. So 30 years ago, using a standard called DICOM, industry decided to actually have a vendor neutral format to store images. And this has created a lot of innovation on the side of the modalities that produce the images, as well as the applications that consume the image. We are trying to use exactly the same concept in managing the structured clinical data, which today, unfortunately, is usually stored in the proprietary format of the vendor of the application. So why are we doing this? You have to think about the nature of health data, which is different than other industries. So in healthcare, ideally, you would keep the data for the lifetime of the patient. Now, it's quite clear that there is no application that will last that long, which is 100 years. So what happens is that every time you switch applications, you need to do the migration of data. And since this means cost of times, we just give up and only have recent data available for a patient. Now, obviously, for the health or the care of this patient, sometimes even what happened at birth is relevant. So for this reason, separating the data from the applications, because they have different life cycles, is actually required. Like I said, the best example we have is from the imaging world, where this has really been the standard way of doing things for 30 years. I think there's a very compelling reason to do this, especially as we move more into patient records, not so much provider records, which is how a lot of information is now being managed.
You've talked a little bit about, and you've given us a lot to think about in terms of the storage standard. Here in the US, all the talk is about FHIR. Can you help us understand how FHIR and openEHR work together? What does that look like?
So the best way to understand this is that FHIR, which is an HL7 standard, comes from the applications towards the data, where openEHR starts from the data and moves up to applications sharing this data. So we come from different directions, but of course, we need to meet in the middle because both are required. There will always be a lot of data in formats that are not open. And in order to use that data, we need to have a common messaging or transport format, which is what FHIR is. They come from very different sides, but they need to work together. And actually, we are one of the companies building a bridge between FHIR and openEHR together with Microsoft. It's really about a different view. I mentioned before this view of, we will leave the data in the format of the vendors, and then we will exchange some of that data, or we will require vendors to store and manage data in an open format, so we will easily exchange data between different application vendors. There's also an important thing to note here is that in Europe particularly, but also in the US, there is this trend of moving healthcare out from acute hospitals towards the home, basically combining data at a patient level instead of the provider organization. And I believe that's the proper approach, because we do want a cradle to grave record of the patient's health history, which is built around the patient, not around the institution that provides care. If you think about it, today, we basically build applications for providers. Of course, we call them patient records, but if I go to 3 providers, I will have 3 different patient records. So obviously, the approach that most of the European countries are taking is that it's either at the national or regional level, or sometimes the city level, that I want to combine all the healthcare data of this patient so that whichever provider he goes to, data can be accessed from a consistent patient-centric care record.
So is that what you mean by the proper structuring of clinical data, that it's being separated from the applications, it's being transformed in some sort of data layer, and then it can be used more facilely?
Yes. So obviously, once you do not allow the vendors to define their own data models, which is the case today, you need a common format. And this is what openEHR provides, a common format for structured clinical data, which is vendor neutral and thus open for anybody to use. You have to get an agreement on this, and this is not easy. So in a lot of cases, especially like I said in Europe, governments, regions are pushing for this standardization, because this will prevent the problems which have built up over the last 20, 30 years by having vendors define the data models which are used to store data. Like I said, again, this trend of putting the data around the patient or making sure that the patient has a consistent record is pushing the industry in this direction.
Another issue in the US is privacy. And it's something that has sort of looked like it's gotten in the way of efficient and effective data sharing. Can you talk to us a little bit about the way that data is protected in a data-centric platform?
Yes, of course. I mean, privacy is an issue worldwide, not just US. I would argue that Europe has passed much stricter laws regarding privacy in the past few years, and it's become a Europe-wide standard and a law. Privacy and access are, of course, interconnected, but if you think that because your records are spread across the healthcare sector, you are much more protected from unauthorized use, I would argue that the reverse is the case, because you do not have any insight into how your data is used at the provider level. So what this centralization around the patient does, it provides a single point where you can actually control access and, of course, also have all the privacy mechanisms in place. So it's the same debate over cloud or on-premise for applications. I would argue that cloud is probably more secure because you have professionals dealing with privacy, access, and security issues. Now, of course, all this means that you do have to have policies in place and a very clear understanding of what is allowed in terms of using the patient's data and what is not. And I think that's the real issue. You know, a lot of times this is hidden in fine print. And I think that's the issue. It's not really a technical issue. It's more a trust issue, but it also needs to be clearly explained to patients. For instance, we run some national systems here in Europe. Our software runs them, not us as a company. And of course, what access control we give to certain users is something that needs to be handled very carefully so as not to prevent provision of proper care, but at the same time not to allow access to anybody who is not authorized.
Interesting. Thank you. Tomaž, in our next podcast, Better's Chief Technology Officer, Alistair Allen, will be joining us. And we'll have the opportunity to hear about some of the examples of openEHR in action. Can you give our listeners a preview of what they might be able to glean from that as to how those examples may be able to be used or replicated here in the US?
Yes, first I would say that we are having this discussion basically due to COVID. So what COVID has done is it's elevated the level of discussion about clinical data to the point where politicians are involved. They now understand that a lot of the struggles they had when making decisions like should we close down the businesses or the country or the facilities were done based on very limited data. So they all realized that the current systems were not providing the data they needed to make these decisions. And thus, at least I can see in Europe, the talk about data is completely different level. So it used to be that people bought applications and didn't think much about data. Now the discussion is about data first and then about the application, which is what we have been saying for the last 10 years. So the examples that we have are at all levels. A lot of them are national. Entire regions like Catalonia have pledged to use openEHR. I'm sure you'll talk about London City, which is just now going live with a solution based on this concept of a centralized care record where the data is pushed out to the end users in 40 hospitals and 2,000 general practices, ambulatory services, everything. And the uniqueness about that is that it's connecting the same data with different users in different organizations, not shipping the data around from provider to provider, but actually having them access the same data, the single source truth. And I believe that that is a model for the future. Now, of course, there's also customers like the Christie, the largest cancer trust in Europe, where the problem is a little bit different. They had different data at data capture. They had another set of data models, data formats they used for their EHR, and then a third set of data formats for research. So with this approach, they're now unifying the data storage of clinical data from capture to research, which of course saves them a lot of time and effort and improves the quality of the data. And then there are 12 of the largest hospitals in Germany who are normalizing data from all their systems and using that to share data for research across the group. And this includes all the big hospitals like Charité in Berlin and Heidelberg. There's many different examples. Slovenia, Malta, Scotland, and Wales have chosen openEHR as the national health record standard. We are now seeing a really big uptake in the Nordics. And this is really interesting because we all understand that the Nordics have been collecting good data in healthcare for over 20 years. They were just not using a standard format, which is now being done. So we see most of Europe actually going in this direction.
Interesting. Thank you.
So this has been a really great conversation, Tomaž, and I think that it's been interesting to hear kind of the difference between thinking about all of the data that's being tracked and kind of siloed in multiple different vendors. And in the US over the past decade, competition has prevailed, and we've created many different EHR, vendors at this point. Which are great. You have a subspecialty vendor that does just for cardiology, and there's a competition within that market for ophthalmology. Each specialty almost is creating all their different specialties, which is great for the providers and necessary because you can't have kind of one size fits all. But as you said, it's creating separate silos, and we really need to think about this from the patient perspective and get the data started from that point. Now, how do you think, based on what you've seen in Europe, if you had to guess, what do you think the likelihood is that openEHR is going to be the solution to solve or help us move forward, at least in the US, with interoperability issues? And second is, do you think this is going to require a government mandate, or do you think the market will dictate it and folks will start adopting openEHR just based on what they need to do to become competitive?
Yeah, so think about this, right? We are not talking about unifying applications. We're talking about unifying data and having choice at the application level. The reason that each vendor uses their own format is a business reason. It's not a technical reason at the moment. So basically, vendors are locking customers to their software for business reasons. And obviously, this is not good for the customer or the patient. Now, of course, a lot of these applications are very capable and they have been instrumental in digitizing healthcare in the US. I'm not saying that's not true. The problem is going forward. And I'll give you an example. Even the largest healthcare systems in the US, over 50% of their IT is not their mega vendor. There's still that other 50% of the applications which need to store data somehow. So in Europe, we usually start there because it's really hard to replace a mega suite. We're not even advocating for that. But what is happening now in the Netherlands, and we just have a project like this starting in Northern Ireland, is taking the data out of those mega suites, normalizing it into an open format so other applications and uses of this data are much easier. So if you ask me how it's going to develop in the US, it's very hard to say, but there are some examples like Intermountain who are trying to do something similar, taking the data out of those systems and managing it separately. And that's a large healthcare system. It's really hard to predict. What I am saying is that, first of all, not even half of the data is in those systems, even in a single organization. So you need to think about that. And then second of all, I really think the data should not be held hostage by the vendor. The customers all agree on this. I have never heard somebody who didn't want data in an open format. And of course, once the patients put pressure on the providers, things are going to change. You can already see this happening now with people like Apple being close to the patient and actually putting data into use from different providers. There's going to be much more of this because we are working towards a world where the patient will have much more control. And this is not only because the patient demands it, but it's also good for their health because of the engagement that we achieve doing this. So this world is definitely changing. Now, whether it's the government that pushes in this direction, of course, that's the last resort. We can see now that, for instance, in the Nordics, especially in Norway, the vendors came to this conclusion and offered this to the market. That's the best possible scenario. It's not happening in other countries, unfortunately. The Nordics are an exception here. But we do see, especially the single payer models, for them, it's a no-brainer, right? Because first, they are paying for vendors' applications which store data in different formats, and then the single payer has to deal with putting all this data together, which is crazy. I think where you have health systems that are powerful enough to influence the vendors, this will start happening. And just recently, we have had Microsoft and EY, as well as Daedalus, which is the largest vendor in Europe, join openEHR Foundation. And this is very recent. Like I said, I think the pandemic made a big change here because the issue of data is now front and center, even at the decision maker level. But I also think that the vendors are realizing that it's going to be very hard to keep the data locked from the patient or the provider.
I think it's a matter of time. And as you said, patients are becoming more savvy now, right? You have your phone that has all of your apps with all your different medical records and portals in it. And I think patients likely will start dictating kind of.
But think about this. Even if you have a portal, you usually have more than one, right?
Right. You're managing 5 different portals for different specialties, and
this is untenable. This cannot continue, right? So it's either you put the patient in the center or the provider, and it's really hard to do both.
Yeah. And I think the U.S. has, identified that one of their goals is to make the system more patient-centric and empower the patients to kind of make their own decisions in their healthcare world. So I think that we're getting there. It's just a matter of how quickly and how it occurs. Well, thank you so much. This has been a great discussion and really good introduction to openEHR for the U.S. markets. Thank you for joining our show. It was really a pleasure having both of you, Karen and Tomaž.
Thank you. Thank you very much.
Thank you to all of our listeners. I'm your host, Nivedita Patel. Coming up in our special series on interoperability, we'll be hearing more from the Becker team, and we'll delve into how openEHR is currently being used to enable patient-centered care in the UK and France. If you like what you heard today, please subscribe to the show. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein, Becker & Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.